you want to say a little bit about the workshop that you'll be doing with Hani van Genderen on working with avoidant patients? Because what I understand from what you're talking about here is that it probably flows out of your experience with this large study and with these range of personality disorders where you've run into more avoidance and probably developed a lot of knowledge base and experience in working with that issue. And you say a little bit more about that.
So in the last trial, many therapists struggled with avoidant patients. Often find them quite complicated. And I think one of the major problems is that it's also in the name of the personality disorder, avoidant personality disorder. They rely on avoidance so easily and so often. And it's difficult for the therapist to break through that. It's important that you do it, but these patients feel so unsafe when they stop their avoidance, and so it's really a challenge for the therapist to not give in too much to this appeal the patient does on the therapist, to not confront them too much and to help them to avoid emotions, problems, memories of childhood abuse, etc. So we will partly focus on some of the methods and techniques to deal with that, and to gently push the patient to give up this avoidance survival strategy, and to help them to feel more comfortable with emotions and to process their childhood abuse memories. Because with many avoidant patients, there has been emotional abuse in the childhood. So
So that's the challenge then in the therapy, is how to keep enough forward movement and keep the rapport solid enough so that the patient will stay in treatment and will be able to deal with facing these painful things.
Exactly. And in a sense, it's a bit more complicated compared to borderline personality disorder, because the borderline patients they are afraid of emotions, but they also switch into emotions. And so you can use that as a therapist. Because whereas the avoidant patient is more successful in always avoiding. So that makes it a little bit more challenging. And the other thing, I guess, is that the borderline patient is looking for safe attachment. The patient is also afraid of it. But he's in a conflict. And if you offer a stable and reliable base, most of the borderline patients will come over that. So they will attach to you after half year after year. And whereas the avoidant patient, I think, doesn't initially feel this need so much for safe attachments. They rather avoid. So
that's working pretty well.
So we address these issues a little bit. Of course, it's not an extended workshop. You could easily spend 4 days on working on that, but we will present some of the basic ideas.
Well, one of the things that comes to mind is that there's sort of two aspects of limited reparenting, and one is responding to needs, so helping the person feel safe and feel nurtured and cared for, validated, praised, and then the other is limit setting or empathic confrontation, and they'll come up with narcissistic patients or someone who's more overcompensating. And when you think about the notion of empathic confrontation, is that the basic framework that you view the approach to dealing with avoidance with these patients? Is empathic confrontation, but just adjusted to in terms of the balance between confrontation and empathy that fits this particular patient?
Yes, I think that's a very important technique, that you both empathize, that you understand that there are avoidance tendencies, that you empathize and understand why they do that and why it's such an important survival strategy for them. But also confront them with that if they continue to do that endlessly, the therapy won't make any sense. So that's a very important technique. The second thing is that limit setting is often mentioned more in the context of overcompensation. But we learned that you also have to set limits with cluster C patients. So if they continue to avoid and are not willing to get more in touch with the difficult stuff, whether it's with cognitive techniques, whether with experiential techniques or behaviorally, you have to set limits, because it would be I think bad practice to suggest that you can help them without any confrontation in any emotional confrontation. You have to do something at a certain moment. So limit setting comes in also, not immediately, of course, but you have to, at a certain moment, if the patient doesn't change the primary avoidance strategies, I think you have to set limits.
Right. Yeah. Otherwise, it's just neglecting them, in a sense, just allowing.
In a sense, from the viewpoint of limited reparenting, is neglecting. And like a parent relying on his or her own healthy adult side could say to a child, I understand that you are very afraid, but you have to do this. For instance, when a child for the first time goes to school and is very afraid of that, and you don't want to give in too much to avoidance tendencies.
Right.
So you know that in the long term the child will grow, and it needs a little bit of reassurance, but also a little bit of being pushed.
Right. I want to thank you for taking the time to meet and to give an overview of these really important topics. The study sounds really significant, and I really look forward to hearing more of the details of the conference and to the study eventually being published. We can get the full scope of that, and the workshop sounds fascinating, and a really important set of strategies that have come out of that in terms of helping this very large group of patients and this major issue in terms of avoidance, because I know that that's been a major challenge within therapies in general and within schema therapies as well, to deal with avoidance, because that can really stall the treatment if we don't have effective techniques for being able to deal with that. So that sounds like a real contribution then that you're offering.
Thank you. I'm looking forward to present and see you in New York.
Yeah, I look forward to seeing you there too.